springing forward. I don't know if it's over 20%, but I believe it's somewhere in that range, 20 to 30% increased risk of heart attacks the day after daylight savings time because people's circadian rhythms are disrupted. So that's the blue blockers. It's still light outside, so I'm going to wear the yellow ones, but once it becomes dark here, the lights go off. Potentially we'll switch over to my red lights in the rooms, but I also have my blue blockers on that are more red, and try to get my circadian rhythms dialed back in. So I'm doing pretty well because I prepared for it yesterday. Have a watch, the Yes Watch, tells you when. It's kind of hard to read, obviously sideways, but it has the sunrise on the light parts of the dial and the sunset, the evening, and the other part of the dial where it's dark, so you can tell when the sun's going to set. And so I know I have about an hour left before I really start getting ready to wind down my blue light exposures. So if you guys are looking to do this next year, at least start a day ahead of time. You want to wear the dark red lenses, in the evening time, an hour or two before you go to bed. Try to get tired an hour before you normally go to bed. I think I didn't do so well the first night, so I just kind of reset it last night. And then this morning just got up at my usual time and feel fine today. So hope you guys are surviving it well. Thank you for those that have answered the call and the poll. And I know we have a few questions to go over tonight. So we'll have at it. So a question about dropping your ApoB below 70 without medications. Their ApoB is 90. They're a hyperabsorber. They eat a low saturated diet. Their BMI is 25 and they exercise. So is it possible? Yes. Is it likely? Not terribly. It depends on where your ApoB started. If it was much higher and dropped down to 90, you're probably not going to get another 20% reduction without adding some type of supplement or medication. You're already answering good questions. If you're not a insulin resistant person and you're not eating a high fat carnivore diet or keto diet that's mostly saturated fat, there's not probably a lot of dietary interventions you're going to do that'll drop you below 70 from this stage. And if you're a hyperabsorber, that's approximately 1 in 5 people that do that. Often ezetimibe is the best option for those people. Question about what is more accurate, an MRI or an echocardiogram? It's going to be the MRI for sure, but at a cost of potentially 4 to 5 times more than the echocardiogram. So the echocardiogram uses ultrasound technology, looking at mostly heart valves, and also you can look at the heart chamber sizes. Cash price of echoes generally between $400, $600. An MRI, if you could pay cash, probably $2,000 to $3,000. So MRI is more sensitive. Oftentimes, if you're looking for a scar, you're going to have to use gadolinium, so added expensive an IV, and the gadolinium, it's not contrast per se, but gadolinium infusion adds up a couple $100 more to do that. So MRI is more accurate and sensitive, but at a much higher cost. Give this one not too uncommonly in my practice. What are my thoughts on methylene blue? It's fascinating. I did IG Live on this a year or two ago. It's going to be in my archives. Also, if you go to my YouTube channel, this youtube.com at Dr. Twyman, spelled like my name up here. I'll drop a link in my post after this to my YouTube channel for those that aren't following me there. That's where I'm putting some of my longer form videos, and all these AMAs go there as well. But methylene blue, the short story is, it helps the mitochondria make energy without oxygen present. But there is a thought that depending on the dose, and the dose is unknown, that will also affect nitric oxide production. And you've heard me talk often about the endothelial function and the glycocalyx. So you don't necessarily want to be taking something that's going to break your nitric oxide production. So I'm from Missouri, you got to show me. So test your arteries, take whatever intervention you're going to do, and retest your arteries. So if methylene blue is breaking your nitric oxide pathways, your arteries are getting stiffer, you have more endothelial dysfunction, you have more increases in your blood pressure, the methylene blue is probably not right for you. But if you have a chronic infection or autoimmune condition and your provider is recommending for that, that may outweigh the risk of lowering nitric oxide, because you can take various nitric oxide promoters if needed. So that's not a qualified yes or no. Got to work with your healthcare provider to know your whole backstory if it's a possible good idea for you or not. Are there any biomarkers that correlate with damage to the glycocalyx? Yes and no. Not directly that you can do in a clinical lab at this time. You can look at glycosaminoglycans in your urine and in your blood, but again, that's not a standardized test yet. That's done in a lot of clinical research trials, that if you have high levels of glycosaminoglycans, which are basically building blocks for the glycocalyx, if you have high levels in your urine or blood, that means that the glycocalyx is getting damaged quicker than it's being repaired. Think of the glycocalyx as like cilia floating on the bottom of the ocean or a riverbed, and it's taking a haircut, and those little cilia grasses are floating downstream, and they're going out into your urine or being measured in the blood. But that being said, you can look at markers of endothelial dysfunction, so pulse wave velocity, endopat. You can look at blood markers such as urine myoglobin creatinine, uric acid, homocysteine, asymmetric dimethylarginine, symmetric dimethylarginine, just to name a few. If those are abnormal, often your glycocalyx has been damaged. Question, what do you do with sky-high numbers if you can't tolerate a statin? So I would add on to the question, it probably means sky-high lipoproteins, particularly ApoB lipoproteins. Those are the lipoproteins that are atherogenic or plaque-forming. Sky high, I don't know how high, I've seen some really high ones in the past, but many people can't tolerate statins, and that's not a reason not to try some other agent. That's the number one side effect people have on statins is muscle symptoms, and it's generally in the low single digits, people who can't tolerate statins from a muscle standpoint, but it depends often on the type of statin, the dose, and the frequency. So sometimes there's ways you can get around it by using the statin at lower dosing or intermittent dosing, and the muscle symptoms are improved. But if you truly can't tolerate statin, then bempedoic acid, which is Nexletol, works in the liver by blocking cholesterol production. You could use PCSK9 inhibitors like Repatha, Praluent, or elasclerin, or you can use ezetimibe to block the cholesterol from being reabsorbed. Those are kind of the main pharmacological ways of doing it. And there are some nutrients and supplements that potentially help in the right cases too. But just because you can't tolerate statin doesn't mean you can't try to get your ApoB numbers to goal. You just have to use a different agent. Good question. What tests do I do for my patients that a typical cardiologist typically does not? So I can do all the same tests that the board certified cardiologists, which I am, do, but I have more of a focus on the endothelial health, the lining of the arteries, because that's the first thing that gets damaged before you develop plaque in the arteries, before you make a trip to the cath lab to get a stent. So I'm not waiting for you to have chest pain, shortness of breath, palpitations before we start looking for your risk factors. So testing that we do in our office at Apollo Cardiology, located in St. Louis, Missouri, if you are so interested in traveling to see us and having us be your cardiologist, is we do testing that looks at your nitric oxide production. So we use salivary nitric oxide test strips to do that. We have a device called the Max Pulse, which looks at pulse wave velocity, so how stiff are your arteries. We look at your central aortic blood pressure with the ACCOR device. That's the blood pressure that comes out of your heart and goes down your heart arteries and up to your brain. We also look at the endopat, which basically is like a stress test for your arteries, tells us how much nitric oxide the arteries can make when there's a vascular stressor. We have a smart ABI machine that looks at your blood pressures in your legs, so we can assess if you have potential blockages in your iliac arteries going to your legs. We have a aorta scan, which is an ultrasound of the aorta that can look for aneurysms. We also have carotid intimomedial thickness ultrasound technologies, so we can tell you how old your arteries are. So lots of things that the traditional cardiologists don't carry. And then we also offer a lot of the advanced lipid panels, mostly through Boston Heart Lab and Cleveland Heart Lab, and you get our very personalized take on what those values mean and how you can optimize your lifestyle, your supplements, and your medications as needed. So that's what makes us different than the traditional cardiologist. Mixing it up. Could I touch on sunlight viewing with and without prescription glasses and contacts? Very good question. Your eyes are not only for visual seeing things, they are light sensors. So if you put glasses on and even contacts between your eye and the sky, that wavelength of light will be filtered. So optimal is nothing between your eye. Naked eyes to the skies is one of my friends, Carrie Bennett, talks about. So if you have the option, you don't wear anything when you're outside. If you just absolutely cannot see without some type of corrective vision, if it's glasses, then tilt them down and look over the glasses and let the full spectrum light get into your eyes. If it's contacts, you got to be very careful with it. If you have any type of chronic disease, autoimmune conditions, significantly uncontrolled vascular issues, you probably want to avoid contacts because contacts block certain healing wavelengths of light from reaching your cornea, particularly UVA light. So wouldn't be a big fan of using contacts if you're very sick. If you're not sick, then it's up to you to decide how much it's affecting your redox potential. So that's my short take on that. But then I always get the question, what about when it's super sunny and you can't see and you're driving? Okay, then wear glasses when you need to do it at that point. But the default answer is if you're staying outside and not doing anything, have nothing between your eyes and the sky. Very good question here. I'm a 34-year-old man. When is it time to start testing for cardiovascular health? Now. Atherosclerosis is a lifelong disease. It often starts, from what one of my mentor talks about, Dr. Mark Houston, starts in utero. You have the potential to start developing things that will develop plaque in your arteries before you're born. It will start with endothelial dysfunction. So this can happen in your teens and 20s. So you want to start looking at things that would affect nitric oxide. Do you have a lot of oxidative stress, inflammation? Do you genetically have high levels of lipoproteins? So especially if you have lipoprotein A, which up to 20% of the population has. So, you get that test one time at, Quest or LabCorp, wherever you like to do your labs. But 34 is a good time to get a baseline, tell you are your arteries aging appropriately? If not, then you can step in at this point and delay the onset, before you get to the point where you're having chest pain, shortness of breath, or a plaque rupture. So what are the best tests under 40? Generally, it's going to be tests that look at endothelial function, like the endopat, potentially a carotid intimomedial thickness scan. Very rarely would a CT angiogram be necessary unless you have a very strong family history of vascular disease in their 40s and 50s. Then you'd want to start checking arteries 10 years before the person started having plaque in your family. But never too early to start. Vascular disease is still the number one thing that takes people out earlier than they hope. So you want to be checking it, making sure the check engine lights aren't flashing red before you have symptoms. I think there's an oral health question. Can the yellowing, browning, graying of teeth have a connection to plaque in the heart? Let's say it qualified possibly. There's a large connection between oral health and vascular health. If you have periodontal disease, you have abscesses, anything that's causing inflammation in the oral pharynx, that's going to be transmitted through your vascular system, potentially damaging the glycocalyx and leading to plaque elsewhere in the system. So if you have a lot of plaque that they're scraping off on your teeth, sometimes that's due to a deficiency in vitamin K2. You need calcium to stay in your bones and teeth. You don't want it building up in your arteries or elsewhere. So you may talk to your doctor about, if you should be on more vitamin K2 if that's happening. But always asking all my patients, that they see their dentist, on whatever schedule that the dentist wants, but generally once or twice a year to make sure there's no oral issues that would be affecting your vascular system. A very good question. And question. What is my recommendations for getting and keeping your A1C under 5.1? So your hemoglobin A1C is an estimate of your 90-day average blood sugar. It's a good test, but not perfect. So I'd also want to know that you have low triglycerides, generally less than 80. You have low fasting insulin, under 8. That you have low ApoB, generally less than 70. That you have fasting glucose, that varies, but generally fasting glucose should be less than 85. Then, if your A1C is under 5.1, then I truly believe it's a true number. Some people have some issues with the red blood cells that just have rapid turnover. So if you have rapid turnover of red blood cells, you're going to have a falsely low hemoglobin A1C. So I shoot for an A1C of 5.1, but the best ways to think about it is that, insulin resistance, it's going to start, in your skeletal muscle. That's something my friend Dr. Line taught me. So You want to focus on high quality resistance training so that you exercise your muscles, and that you eat high quality protein so that your muscles have the building blocks to put down more muscle units. So focus on your muscle health. Dr. Line has a very good book out, Forever Strong, if you want more details about that. And here's a question. I'll put it up, but I don't really have an answer for it yet. I might have to do a little bit of research, but somebody's asking about, does carbon dioxide play a role in vascular health? If so, how can we cultivate it? I mean, carbon dioxide does vasodilate. It's what is one of the end products of respiratory chains in your mitochondria. So it does play a role, but like what exactly you're asking, I'm not quite sure. So let me do a little bit of research and I'll try to get back to you about that. All right, so those are all the pre-formed questions. So let me see what else is popping up in the comments here. So I'm not quite sure what this question from Nanny is about. It says, what is more important to check, lipo-A or I think it says lipo-B. So first you want to check for apolipoprotein B. This is where it does get a little bit semantics, and sometimes it gets a little bit challenging, but I'll try to kind of break it down for you. So cholesterol, it's the fatty, waxy passenger inside the cargo ship. The cargo ship is the lipoprotein, the lipid protein carrier. In my office, I use a tennis ball analogy. So the lipoprotein is the tennis ball, the cholesterol goes inside the tennis ball. On the outside of the tennis ball, the white stripe, that's analogous to apolipoprotein B. It's a protein on the outside of the lipoprotein. The ApoB is essentially a structural protein. It holds the tennis ball in a sphere and then acts as a ligand, or basically a key to fit into different receptors. On the outside of your liver, you have these LD receptors. They're like catcher's mitts to grab those tennis balls as they go by. Now, lipoprotein A is like an LDL subfraction. It looks just like an LDL particle, but has an extra protein on it. That extra protein is an apolipoprotein A. That apparently looks like a pastry that I believe it's the Dutch make, that is called a kringle. So the kringles are the apolipoprotein A. So ApoB, everybody has it. What level? There's a large genetic predisposition. There's nearly 3,000 genes that affect your lipids. And so some people, despite their best efforts at lifestyle interventions, they're going to have very high lipoproteins. But lipoprotein little a, or LPA, that's under large genetic control. Approximately 1 in 5 people have high levels of lipoprotein A. So you just need to check lipoprotein A at least once in your life. If your level is normal, then it will never be high. But if your level is high, a little bit of debate, should you continue to check it? And the answer right now is probably maybe. But once they develop drugs that effectively lower it, and those are the antisense oligonucleotides, and there's a couple other classes, then possibly you would repeat it to see, like, okay, we've given you the drug intervention, how much did the LPA lower? And in the trials, it's lowering well more than 90%. So at this point, if your levels are high, probably not necessary to check it every single time. Just check the ApoB and get that down to goal, because most of the atherogenic particles are going to be on the outside of your LDL particles. Question about heart rate variability. When should one be concerned about a downward trending heart rate variability? Well, first off, is it truly downtrending is what I always ask people. What device are you using to measure heart rate variability? If you're using a ring or wrist-based strap, it may not be actually accurate. So that is the first case. So if you really want to know, the only way to really look at a HRV accurately is using a chest strap that's measuring the RR interval on an EKG. All the photoplasmography devices, they're estimating your heart rate variability. So first, track it. So I tend to like the polar straps, for the kind of the beginner. There's now H10. I think I have the original H7 model. And then you can use the Lead HRV app to track it. But I have what's quote the Ferrari of chest straps. I have the Frontier and the X2 model, and it does strain imaging. You can do an EKG live while you're exercising. not necessarily for everybody, but I'm kind of the biohacking cardiologist, so I like to play with the toys first before I recommend anything to people. But the Frontier actually has the most accurate HRV that I've seen to date so far. But back to your question, if it's downtrending, it depends on how far off of your trend it is, and also just how do you feel. HRV is not a perfect metric, but it's often a sign that you're either overtraining if you're an athlete, or you're potentially getting sick. If you're getting an infection, often the HRV will change 1 to 2 days before you actually start feeling symptoms. So just think of it as a check engine light and look at other things as well. And then I see that Healthy Life Nation series has joined. So this is Angela Lamb, who I previously had the pleasure of being in a documentary with a couple years ago. This was the Uninflame Me documentary that is on Amazon Prime. The Healthy Life Nation TV series I was part of, and there's 3 episodes. One of the episodes definitely rhymes with what we're talking about today. I talked about circadian rhythm management. We're talking about blue blocking glasses in that episode. There's an episode about photobiomodulation or red light therapy. And they also did an episode about cold thermogenesis, where I jump in the cryo tank. So that series is now available on Amazon Prime, which is awesome. Congratulations, Angela. But I also saw today that you got it on Apple TV. So I'll share the link to the Amazon Prime version in my stories when we're done chatting here. But if you want to see me on a, quote, TV series, check out Amazon Prime. And somebody's asking, what do I think of Repatha as an alternate to statins? I think it's a great option. The really only downside is the cost. And for some people, that it's an injectable medication. It's a twice a month subcutaneous auto pen. Most people don't complain about the injection. It's a very, very small, fine needle, but it's really the cost. If insurance doesn't cover Repatha, it's a ballpark about $500 out of pocket cost per month for it. That being said, if the cost was no option, it's a superior agent at lowering lipoproteins than statins. It's more effective at the effect on the LDL receptor. So on the outside of your liver, again, you have these LDL receptors like catcher's mitts that they're grabbing the ApoB particles as they go by. So I've told the story before, but I have a great grandmother who lived 106 years old. She was on no medications, didn't see doctors. She ended up dying of pneumonia at 106, but she lived alone until she was 100. And I have many family members who have, quote, low cholesterol. Well, eventually did some genetic testing on them and found out that they had a loss of function PCSK9 gene. That's the gene responsible for the enzyme that degrades your LDL receptors. So if you don't make that enzyme, your LDL receptors stay out all day long, plucking ApoB particles as they go by. So the drug companies developed Repatha and then Praluent and now Ilisclerin to model what my great-grandmother had. Just a fun fact. And before that, you ask, no, I did not get that gene. I'm more like the average person, so I have to do more to try to modulate my ApoB. Question about what are some of the causes for leaky heart valves? Infection would be one. Myxomatous disease, which is more kind of congenital, where you develop mitral valve prolapse. So probably some issues with collagen and elastin. Uncontrolled high blood pressure would be one. And endocarditis, if I haven't said that, so an infection of the heart valves. Certain autoimmune conditions can have an effect on it. And so it really depends on the severity. Is it trivial, mild, moderate, or severe? If it's more trivial or mild, probably not symptomatic. More moderate, severe, might be more short of breath or having heart failure symptoms. So something that you would need to know what the baseline echo showed and then repeat the echo at an appropriate interval and see if anything changed. All right. I knew this question would pop up at some point, but thoughts on Wegovy for reducing cardiovascular risk. So that was the big news in the past week that the FDA approved Wegovy. It's the first weight loss drug that's been approved at lowering MACE, major adverse cardiovascular events. Is it significant? Possibly. But, is Wegovy for everybody? No. There's a lot of side effects to these type of medications. So, my main concern is when people lose more muscle mass than they were expecting, and then they stop the medication and they have, weight gains that go back or even more than what their baseline weight was before they start the medication. So if you focus on muscle-centric medicine, if you focus on resistance training and high-quality protein, that won't necessarily happen to you. There are some other concerns too that it affects your heart rate and heart rate variability. So for people wearing these trackers, they'll notice the heart rate is increased. That just means there's some type of stressor on the cardiovascular system. So I think if you're 100 pounds overweight, if you're actually diabetic, I think these medications make a large reduction or large benefit for you. You have 10 pounds to lose, probably not the best medications. I would say focusing on high quality sleep would get you better benefits than considering these medications. Somebody's saying, what are vascular tests? I spoke about them earlier, but testing that looks at vascular endothelial function, looking at intimal thickening, calcifications in the arteries. There's multiple blood tests, so it depends on what you're interested in, but we do a whole battery of them to look at the health of your arteries when you come see us at Apollo Cardiology. How can you lower lipoprotein A? Do statins help? The answer is statins do not help lipoprotein A be lower. They actually oftentimes increase lipoprotein A levels. There are not great effective treatments for lowering lipoprotein A. Niacin may do it a little bit, but probably some side effects causing some HDL dysfunction in some individuals, may raise blood sugar, may raise liver transaminases. So hard supplement to use at appropriate doses, and you're generally only going to lower lipoprotein A maybe 20%. Estrogen can help lower lipoprotein A. So if you're a woman who's menopausal and there's appropriate indication for vasomotor symptoms, hot flashes, then estrogen replacement therapy can lower lipoprotein A, but people should not start estrogen just to lower lipoprotein A. The previous mentioned Repatha, Praluent, those show that there's some benefit at lowering lipoprotein A, maybe up to 30%. And I've seen some patients do that personally, but it's one of those cases where they need to be on Repatha because they got familial hyperlipidemia, or they're already had cardiovascular events and on maximally tolerated statin and can't get to goal. Insurance companies will not cover Repatha or Praluent just to lower lipoprotein A. You got to be on it for another reason to get the added benefit that LPA is lowered. Now, the most effective way to lower lipoprotein A is apheresis. They basically take your blood out, put it through a machine, take out the lipoprotein A, and give you your blood back. That's available at a few specialized centers, more popular in Europe. That's the only effective way to significantly lower it at this time. Question, is lipoprotein ApoB of 148 too high? Likely. That would be well above the 90th percentile. So 90% of people have values lower than that. But again, show me, what is the health of your arteries? Do you have healthy endothelial function? Do you have vascular inflammation? Do you have hard plaque in your arteries, soft plaque in your arteries? If the answer is yes, then that's definitely too high of a number. If your number is high, but you have healthy arteries, then it's a kind of monitor situation. But it's really kind of your risk tolerance. You're the person taking the risk, leaving it high. You're also the person at the risk taking a supplement or medication to lower it. So, always test the arteries and know what you're dealing with. Does high lipoprotein A correlate to high ApoB? Yes, they are connected because lipoprotein A always has an ApoB protein on the outside of its particle as well. Now, the lion's share of the lipoprotein, the lion's share of the ApoB is going to be on the outside of LDL particles, but the LPA ones tend to be more atherogenic, 1.5 to 2 times more atherogenic than a regular LDL ApoB particle. I don't know exactly what question you're saying. Can you recommend some non-CMP test to ask a doctor on their next blood work? They've looked at insulin sensitivity, but would be more proactive with other tests. They just turned 24. So I usually lump them into 3 buckets. Tests that look at nitric oxide and things that would break nitric oxide production. Number 2, oxidative stress and inflammation markers. Number 3, the lipoproteins. So bucket 1, that would be urine myoglobin creatinine, ADMA, SDMA, uric acid, homocysteine, which is off the top of my head. The oxidative stress inflammation markers, high sensitivity CRP, GGT, OXLDL, oxphospholipid ApoB, LPPLA2, myeloperoxidase. And then the third bucket, the lipoproteins, just a NMR analysis, ApoB, Lp(a), and probably your ApoE genotype if you've not had that previously checked. That'd be a good starting point. Somebody's asking, how do they find a local cardiologist who can test endothelial function? That's going to be the magic of Google. See if they have search engine optimization on. There's a few places that have it, not many, but you have to usually be in a bigger city and have a cardiologist who's actually interested in looking at prevention and not just treating heart attacks and symptoms. All right. So that was a quick 30 minutes, guys. If there's any other questions popping up, I'll answer them. But hope you guys are, tolerating daylight savings time. I wish it wouldn't switch. Obviously, I'd be preferable just to say that, when we fall back in the fall, that's it. We stop doing this, because when we mess with our circadian rhythms, we mess with our vascular health. There's higher risk of heart attacks today because people don't get optimal sleep. You optimize your circadian rhythms by two main zeitgebers: the light that enters your eyes and the timing that your nutrients come in. The food one's easy. You can do this anytime. When the sun's out, you can eat. When the sun sets, stop eating. That helps the body know that it's nighttime. The light one, you've probably never seen me without these glasses on unless you sit down with me in the office, and my office is all circadian rhythm friendly. But, I'm up before sunrise. I wear the glasses. I keep my house dim. I have some red lights on so you can see walking in the hallways. I go out at sunrise. I do not wear the glasses, and I let light hit the back of my eyes. The melanopsin receptors get stimulated by the blue light. Tell your supracosmic nucleus, hey, it's morning time. Start making cortisol. Start making your sex hormones. Then, when it's nighttime, the sun sets. No more blue light supposed to hit that melanopsin receptor. Your body knows it's nighttime. You recreate that by keeping your house dim. You can use red lights or fire, or wear your glasses. I'm pretty sensitive, so I only wear my yellow ones till maybe an hour before bed. I usually do not need to wear the dark tinted red lenses because my circadian rhythms are pretty entrained normally, but on this daylight savings time, I will use them just to kind of ensure that I'm entrained better. So I'll throw the red lenses on about an hour before I want to go to bed, and then try to fall asleep at my normal time now, and then wake up at my normal time tomorrow. Consistency. So I'm up by 5 a.m. every single day, 7 days a week. Very rarely if I travel, I'll kind of adjust it a little bit. But the better you can train your rhythms the rest of the time, daylight savings isn't as big of a challenge for you. For those that joined late, was talking about that there's a Healthy Life Nation TV series out where I did 3 episodes with Angela Lamb, the creative director of it. We do 1 that's on circadian rhythm and blue blockers. 2, we do 1 on photobiomodulation or red light therapy. And 3, we do 1 on cold thermogenesis. And I was in a cryo chamber explaining that benefit. That was recently picked up on Amazon Prime. It's also, under my understanding, on Apple TV. Funny side note, the first show that I did with her, Uninflame Me, for many years ago, that was way before I knew a lot of this biohacking and circadian rhythm stuff, so definitely not wearing the glasses then. But that got picked up for Amazon Prime, and so then when I'm scrolling through Amazon, that often I watch a lot of documentaries and health series on TV, and that often just pops up into my feed as you might want to watch next, and then it starts playing and it's me talking at me, which is always a surreal experience. But if you're interested in seeing the new series, I will put a link in my stories after I'm done chatting with you guys. You can go check it out on Amazon Prime or Apple TV. Also, I'm starting to put together some longer form videos on my YouTube channel. My YouTube channel is just youtube.com/Dr. Twyman. I'll put a link in my stories as well for that. So I'll be back next Monday, 6 p.m. Central Time. Same story. I'll be using the good podcast mic that you guys like better. And so we'll see what you got for me next week. So have a great week and take care.